Good afternoon, everyone. Welcome to this OncLive News Network presentation. We are broadcasting live from MGH Studios today. Today's discussion will be focused on the cardiovascular complications of androgen deprivation therapy, which we also refer to as ADT in patients with prostate cancer. I'm your host, Deepthi Gupta, a member of the Cardiology Service at Memorial Sloan Kettering Cancer Center in New York. I'm joined today by my colleague, Dr. Susan Slovin, attending member of the GU Oncology Service, also at the same institution. During the next hour, we will navigate through some of the questions regarding the use of androgen deprivation for prostate cancer. We will walk you through the metabolic and cardiovascular side effects of ADT, and we will review the differences among available agents, as well as go through the optimal management of patients with cardiovascular disease and risk factors, both before and during the therapy. During the last few minutes of the broadcast, we will answer questions on this topic from our viewing audience. We invite you to submit questions to our panel by using the entry field, which you will see located right below this video. To start off, Dr. Slovin will start us off with a review of how we use androgen deprivation, its effect on hormone-sensitive prostate cancer, and the long-term adverse sequelae we see associated with the use of ADT.
Thank you, Dr. Gupta. And yes, most of you probably know by now that prostate cancer, just like breast cancer, is a hormonally driven disease, except the prostate is driven very heavily by testosterone. Androgen deprivation therapy, or blocking the ability of the body to make testosterone to feed the tumor, remains a mainstay of treatment, and it certainly has remained the standard of care for patients who present with metastatic disease. It's also a mainstay of therapy in people who have high-risk disease, as characterized by PSAs greater than 20, Gleason scores of 8, 9, or 10, or very large, bulky prostate. It's also very important nowadays in the development of control of patients who have metastatic disease at diagnosis. Now, androgen deprivation therapy, as many of you know, had its incipience in orchiectomy, and that meant that just removing the testes was a way of making sure that castration was permanent and thereby discontinuing the production of testosterone. It's really been a very different field since the development of gonadotrophin-releasing hormones, GnRH analogs, or more recently, antagonists. GnRH agonists have been known as leuprolide, groserelin, buserelin, triptorelin, all by a variety of different names depending on the manufacturer and how long there are depot formulations. And then, of course, there's a GnRH antagonist, degarelix. Anti-androgens are often given with GnRH agonists. They go by different names: flutamide, nilutamide, bicalutamide, and they bind competitively to the androgen receptor in the cells. They inhibit its activation, but they themselves alone do not lower serum testosterone levels. And in fact, if you use it as single-agent monotherapy, you will actually find that testosterone levels will be skyrocketing, but does not actually affect the growth of the cancer. So ADT, first-line treatment with metastatic disease, either given alone or in combination with anti-androgens, but more recently, based on a variety of very high-profile phase 3 trials, we now have learned that one could use androgen deprivation therapy early on at the time of diagnosis if somebody has metastatic disease. Both the CHARTED and STAMPEDE trials have shown excellent disease control and improvement in radiographic disease progression by introducing either hormonal therapy alone or hormonal therapy along with docetaxel. Similarly, patients who have, again, metastatic disease have also shown a benefit based on 2 other trials, mainly STAMPEDE and the LATITUDE trials, using an androgen receptor signaling inhibitor such as abiraterone. So overall, we do know that we can improve survival in our patients using androgen deprivation therapy, at least inducing tumor responses in greater than 90% of patients with advanced disease, albeit that the time to resistance may be very variable.